So now we've reviewed the risk factors for falls in community dwelling older adults and the evidence-based interventions. Now I'm going to talk about the STRIDE study, which was an NIA PCORI funded pragmatic trial. It was conducted across the United States to try to integrate fall prevention evidence into primary care practices. And so our objectives are to explore strategies for applying fall prevention evidence in primary care practices and to understand the findings and lessons learned from the STRIDE study. So first, a little bit about the STRIDE team. So we had 3 overall PIs on the STRIDE study. One was Shally Basheen from Partners, Tom Gill from Yale, and David Rubin from UCLA. And we were 10 clinical sites, trial sites across the US, which encompassed 86 primary care practices. I was the site PI for the Partners STRIDE team. Right now, Partners has changed their name. We're Mass General Brigham. And our data coordinating center was Yale. So what was the STRIDE intervention? So we had a co-management model whereby we had a falls care manager that partnered with the primary care provider in all of the practices. There was at least one in each of the geographical sites. They completed an in-depth fall risk assessment on the day when the patient went to see their primary care provider. And so based on that assessment, they worked with the patient to develop an initial plan of care that was focused on their personal risk factors. And once that plan was approved, they had a call with the provider, and then based on any suggestions or refinements, they then worked with the patient to implement it. And we followed the patient over a period of 2 years. This is a picture of the patient-centered fall prevention care plan. And so on the left-hand side, these are the common risk factors for falls in the community. And so this was the template that the nurses would use, the falls care managers would use with the patient to find out, to first identify with them the risk factors that were present for them, and then to work with them on identifying which of the risk factors were a priority for them. And we encourage the patients to pick, when they had multiple risk factors, to try to work on at least 3. This is the STRIDE patient follow-up structure. So the initial visit was done when the patient was having an annual wellness visit or an annual visit. And at that point, that's when the nurse did the initial full fall risk assessment. Once that was approved by the PCP, the nurse called the patient and did some follow-up, talked about what were the steps they were going to take to implement the plan. And then at 3 to 4 months, there was a follow-up call to see how they were doing. There was a 6-month visit in the PCP office, or they could get a home visit from the nurse if they preferred that. At 9 months, there was a follow-up call, and then the year two visit was the end of their follow-up period. So our inclusion criteria: patients had to be at least 70 years old. They had to fail the risk screener. So that meant they had to say yes to one or more of the following questions. Have you fallen and hurt yourself in the past year? Have you fallen 2 or more times in the last year? Are you afraid that you might fall because of balance or walking problems? The exclusion criteria that we had are that the patient is enrolled in hospice, that they reside in a nursing home, that they weren't capable of providing informed consent, and they didn't have a proxy, and the patient didn't speak either English or Spanish. And so we really tried to have very few criteria because we wanted the intervention to be generalizable. Our STRIDE research question was, can redesigning primary care medical practices and engaging patients, reduce serious fall-related injuries, and improve other outcomes within real clinical care. And so our primary outcome for the STRIDE study was serious fall-related injuries, and that was operationalized as injuries that led to medical attention, including non-vertebral fractures, joint dislocation, head injuries, lacerations, and other major sequelae. And these were all adjudicated using electronic medical records. And then our secondary outcome was all injurious falls, and these were patient reported. So all falls regardless of injury. And we also measured well-being, fall efficacy, anxiety, depressive symptoms, physical function, and disability. So what did we find? So the demographics of the patients that participated in our study, we had about 5,400 patients from 86 clinical practices. The mean age was 80. 62% of our patients were women, over 90% white. Most of them had a college education or higher. And about close to 40% had a fall with an injury during the previous year. So that was self-reported based on their screening. And about 35% had 2 or more falls during the previous year. I talked about the different risk factors, and in our last section, the most commonly identified risk factors in our cohort were problems with strength, gait, or balance, osteoporosis or vitamin D deficiency, and vision impairment. So for our primary outcome, which was first adjudicated serious fall event, we saw an 8% reduction, which was not statistically significant. So there were 4.9 events per 1,000 per 100 person years of follow-up in the intervention group, and 5.3 events per 100 person year in the control group. Our secondary outcome of first participant reported injury from a fall, we saw a 10% reduction. That was significant. In the intervention group, there were 25.6 events per 100 person years of follow-up, and in the control, 28.6 events per 100 person years. So STRIDE was a pragmatic trial. Our patients and providers faced all of the challenges that all patients and providers face when trying to implement evidence-based care, including barriers to follow-up. In 2015, which was our first intervention year, I remember we had 108 inches of snow in Boston. In 2017, there was a Hurricane Harvey in Galveston, Texas, that made it very difficult. Both of these events made it very difficult for patients to come in and very difficult for providers to follow up. We did see a decrease of 8%. That wasn't significant. So despite the fact that falls are increasing in older adults, based on this study, it appears that the rate of injuries is down. So STRIDE, we powered STRIDE based on injury rates that were reported in the literature. We had hypothesized a serious injury rate of 20% in the control cohort, but the actual rate was 50% lower at 10%. We did measures that reduce risk in the setting of a clinical trial, maybe are less effective when we face real world challenges. Some of the things that we saw a lot in STRIDE were difficulties with patients securing transportation. The cost of follow-up care, sometimes even the copay was a barrier to people following up. Behavioral interventions are not monitored, so we tried very hard to get people to enroll in exercise programs, to do home exercise, and of course it's self-report and was not monitored. We did use motivational interviewing. We did try to engage patients in the risk assessment and developing the personalized plan. This did allow patients to select interventions that they're most willing to implement, but sometimes the ones that people are most willing to implement are not the ones that would potentially make the most difference. Improving quality of care for falls may not be sufficient to reduce serious fall injuries. So To achieve a larger reduction in serious fall injuries, we think that improvement is needed in the delivery and access to the key interventions like exercise and really making that systematic for older people.